Pavord, who speaks on monoclonal antibodies in COPD. Please, Professor.
So I want to apologize first off for talking about Bologna University earlier on, because of course we're in Modena. Sorry, Leo.
Oh, you anticipated something.
Now, Modena University is the third. It is the third oldest university, and founded 20 years after Oxford and 30 years after Bologna. So apologies for that. I suppose it's a regret that I don't have any positive data to show you, so I think we can probably run through this quite quickly and hopefully have discussions more generally around biological treatments. So, Fan's already covered this. We've learned a lot about airways disease from our initial forays into the biological era. There are real prospects for T2 or Th2 cytokine blockade in COPD. Other biological approaches are highly uncertain, and we really do need more information to make progress. Guy's shown this right-hand pathway, potentially involving ILC and alarmins released in response to pathogens and pollutants, may be particularly important in eosinophilic airway inflammation in patients with COPD. Now, mepolizumab, which was the first modern biological to evaluate, doesn't work in asthma against asthma-related outcome measures. Fan has shown this data. Despite being biologically active, it failed in the clinical trial of asthma as we perceived it in the late 90s, early 2000s. But it is highly effective in eosinophilic airways disease. Measures that we traditionally rely on to identify asthma, like bronchodilator reversibility, allergy, the absence of smoking, are not associated with a treatment response. So this is not an asthma treatment. It's a treatment for eosinophilic airways disease. In fact, when we looked at the early HALDA study, the more bronchodilator responsive the patients were, the less well they responded to mepolizumab. So this criteria very likely involves a mechanism that is entirely divorced from type 2 IL-5 mediated inflammation. The DREAM study, which Fan showed, a 600-odd patient study, in 95 patients had COPD-like disease. If they'd smoked for one more year, they would have got into all recent COPD trials. If they'd told the truth about their smoking, they would have got into all recent COPD trials. So they had adult onset disease, smoking history, and fixed airflow obstruction. So that's COPD. These patients did very well with anti-IL-5, and it's a great regret that I can't show you positive data with this. Because of our old-fashioned concept of disease, we have to do entirely separate studies in asthma and COPD rather than doing one study in eosinophilic airways disease. When we look at the MENSA, the phase 3 trial, and we focus our attention on the patients with a raised blood eosinophil count, more than 500 millimeter per microliter, the effects of this treatment are huge and life-transforming. So 80% reduction in exacerbation, up to 300 ml improvement in post-bronchodilator FEV1, and this measure, St. George's Respiratory Questionnaire, which traditionally is a COPD measure, is actually the most responsive measure to mepolizumab. Look at these changes. Between 8 and 11. What do you get with Seretide? Between 2 and 4 improvement in St. George's. So this is a very big impact in a defined group of patients with eosinophilic airways disease. There is only one study that I can show you looking specifically in patients with COPD, and this is with benralizumab, which targets the IL-5 receptor. An important difference, as I'll come to in a minute. This was a 100-patient study. The patient enrollment was not perfect. Despite this, I think that there is a strong suggestion of a positive clinical effect in patients with higher blood eosinophil counts. This drug is being evaluated in phase 3 trials, as is mepolizumab and reslizumab, and we will know before this time next year whether it works, but of course it will. There's no question. And we have other options, including anti-IL-13 and dupilumab, which targets IL-4 and 13, which may also have a role in eosinophilic COPD. Interestingly, as Fan alluded to, these drugs have very different profiles of effects on biomarkers, and we may be able to use these biomarkers to tease out which drug to go to which patient. They have remarkably similar clinical effects, with a big effect on exacerbations and relatively less effect on symptoms and lung functions, with the exception of dupilumab, which looks a little bit better than all the others. We learnt about, and I think the real opportunity for biological treatments is in the treatment of acute exacerbations of airways disease. And we learnt a lot about these from this work carried out by Mona Bafadal, who's now in Oxford with me, where she looked at a cohort of patients and assessed them not only when stable regularly, but also when they had an exacerbation. And she was able to show, using traditional clinical measures, but also biological measures, that there were 3 major groups of patients at the time of exacerbation. And the group of interest is that where there was a sputum eosinophilia. And this was the second most common pattern of disease we saw in acutely wheezy adults presenting to us after an infection-related airway disease. And there was very rarely overlap between these 2 major patterns of disease. There was another group who had viral-associated exacerbations. And although these events were clinically completely indistinguishable, they had very different biological characteristics, suggesting that a precision targeted treatment approach may work very well in this problem. Eosinophilic exacerbations tended to be worse, so the patients had a bigger dip from their normal baseline status compared to non-eosinophilic exacerbations, but they got better very quickly. Here's the time to recovery, and it's much quicker with eosinophilic than non-eosinophilic exacerbations. So the profile of these events looks different. Blood eosinophilia emerged as a very good biomarker of exacerbations associated with a raised sputum eosinophil count. And you'll keep hearing me talk about 2%, but 2%, which is 150 cells per microliter, largely rules out active eosinophilic airway inflammation. So if your patient's below that level, they don't have the pathology. So that's why we keep focusing on 2%. A value of 270, the upper limit of normal range in Ghent University Hospital, is associated with an increased risk of lung attacks, mortality. So this could be a biomarker of a high-risk group of patients who have severe exacerbations. Can we use biology to target our treatment approach in patients with exacerbations? This is a meta-analysis that Mona Bafadal did, looking at 3 studies that have compared placebo or inactive treatments with prednisolone in patients presenting to secondary or primary care with acute wheezing illnesses. And in all 3 studies, we had access to the pre-treatment blood eosinophil count. And I've stratified the outcomes by blood eosinophil count, again using 2%. Now, if your patient does not have eosinophilic airway inflammation and is given prednisolone, they have a high treatment failure rate, defined as needing escalation in care or retreatment within 1 month, or death within 1 month of the event. So there's no benefit of prednisolone in this group of patients, although it's widely used. In contrast, in the patients where eosinophilic airway inflammation may well be present, prednisolone has a clear beneficial effect. So targeted treatment of acute wheezing illnesses looks attractive and has potential. I think this drug will change the way we manage acute wheezing illnesses. Benralizumab, which targets the IL-5 receptor, is able to deplete circulating eosinophils very rapidly because they are eaten up by macrophages after being complexed with natural killer cells. So you see, within 1 day of the first injection, a complete depletion of blood eosinophils. And you don't see that with reslizumab or mepolizumab. And this is exactly what prednisolone does, of course, is rapidly deplete circulating eosinophils. And I think that benralizumab has great potential as a treatment for eosinophilic acute wheezing illnesses. And in support of that, this a small study in asthma showed that 1 injection of benralizumab at the time patients presented to the emergency room with an acute attack markedly reduced the rate of recurrent exacerbations over the next 180 days. And so the ability to give 1 injection, potentially in place of prednisolone, which will not only treat that acute event but prevent recurrences for a prolonged period, I think is a great advantage in a group of patients at a very high risk. What about T2 low treatment? Well, this is a much less uncertain area. And we really do need to go back to the drawing board with type 2 and stop, I completely agree with Fan, stop doing expensive, big clinical trials until we know more. There is some encouragement. Macrolide antibiotics work in this pattern of disease. They work very well in patients with bronchiectasis, quite well in patients with COPD, and a bit in patients with asthma. Suggesting that they target a endotype, if you like, or a pathway that's particularly prevalent in this group of patients. And I suspect it is infection-related neutrophilic airway inflammation, but there's no proof of that. CXCR2 antagonists are biologically very effective. They greatly reduce blood, but particularly sputum neutrophil counts, so they're the mepolizumab of the neutrophilic airway disease. They have biologically huge effects. And in this small study in asthma, some clinical benefits, but in COPD, the data has been very negative and very disappointing. Now, there is some interesting details that I want to share with you when we look at the response to macrolides and CXCR2 antagonists by smoking status. So with macrolides, smokers don't respond to macrolides, but ex-smokers do respond very well, whereas with CXCR2 antagonists, we see exactly the opposite. So smokers benefit, quite markedly in fact, whereas ex-smokers seem to get worse. Now, we need to be very cautious about looking post hoc at data like this, but I find this compelling, and I wonder if we're dealing with at least 2 types of neutrophilic airways disease that differ in their relation to infective pathogens, which respond to macrolides, and exogenous stimuli such as cigarette smoke, which respond to CXCR2 antagonists. Infliximab, which is an anti-TNF, has been trialled in COPD, and the results were resoundingly negative. But the major finding was that there were significant safety issues with anti-TNF. So a high rate of malignancies, and as shown in the asthma study that Fan showed, a high rate of infection-related morbidity. So this approach will not work in an untargeted way, and probably will never be tried again. So I'll finish there. I think type 2 targeted biological agents look like a good bet for eosinophilic COPD. They will work. We may have to play around with the criteria, but I'm quite sure we will have another treatment option. There's a big opportunity which I see, unfortunately industry doesn't, for the treatment of acute wheezing illnesses associated with an eosinophilia, particularly with benralizumab. Non-eosinophilic COPD and airways disease in general, I think, is too difficult at the moment for us to invest any significant capital in. We need to go back to the lab and define the subphenotypes before we can make progress. Thank you.
Thank you, Ian. The presentation is open to discussion. Professor Fabio, please.
Yeah, thank you very much. I mean, you distilled out very useful messages out of this difficult review. Now I'm challenging you as a clinician. And the COPD we are addressing in our study is the COPD we know, and is mainly COPD. We exclude the others. So my question to you is, the COPD that you see in the clinical setting is just a small component of a much more complex patient that has different. And the two I'm mentioning are, on one side, heart failure, and on the other side, lung cancer. Now the question is, from your experience or from reading the literature or so on, is any evidence, for instance, that chemotherapy that is used for lung cancer, that is actually modifying the leukocytes and is actually affecting all COPD? And on the other side, is any evidence, apart from statin that we know they are negatives, that treatment for heart failure or ischemic heart disease may actually contribute to target the COPD component of that complex patient? I know it's a difficult question, but I'd like to have your gut feeling on that.
Chemotherapy and COPD, I'm not aware of any data, but of course in animal models I think drugs like hydroxyurea have been used to deplete circulating neutrophils, and perhaps other people would know more than me what the clinical effects are, for what it's worth, in an animal model. The possibility that biological treatments might alter the risk of cardiac and malignancy morbidity, I think, is a troubling. We don't have any data thus far, but of course if we're going to see something, it will be in the COPD population, who have so much more comorbidity. I think we should learn from the anti-TNF study, because the risks of malignancy was extraordinarily high when you block that cytokine, much higher than in rheumatoid, and the risks of infection likewise. And you would have to conclude from that TNF is critically important in patients with COPD in protecting them against malignancy and infection. And I think that's an important clue that we need to think about, and so that whatever that cytokine does in terms of tumor surveillance is very important in this group of patients. So we have to learn from from disasters as well as from successes, and that was a disaster, I think. Yeah.
Another question?
Hi, and thanks for the presentation. Two considerations. One is in the Pavord study, those patients with eosinophilic type of exacerbation, they have already high eosinophil at baseline. They were more eosinophilic in stable condition. Do you think that the prevention with corticosteroids, inhaled corticosteroids, is limited to this type of exacerbation, the eosinophilic one? And then our comment on interleukin-5 in COPD related to the benralizumab study, which is not as positive as in the asthma one, of course. As far as you know, is it eosinophilia in COPD driven by interleukin-5 as much as it is in asthma? Should we expect the same type of result, or is it something else? Your taxon or whatever?
Well, the effects of treatment on blood eosinophil counts is just as large in COPD as it is in asthma, which is only a partial answer to your second question. And the first question was relating to... So,
Yeah, they were already...
oh, yes. Yeah. So baseline status is highly predictive of status at the time of exacerbation. Yeah. Yes. Yeah. And we've got very good data with mepolizumab that where Pranab Halder in the first proof of concept study looked at patients when they presented with an exacerbation, and what the impact of mepolizumab was to take away the exacerbations associated with eosinophilia. Yeah. But there were still a lot of exacerbations that were neutrophilic. Yeah.
Ian, I think we all agree that we shouldn't really be talking about asthma, COPD, and ACOS. I think I'm hoping that next year when you have the meeting, Leo, that you will call this meeting not asthma, COPD, and ACOS, but chronic airflow disease. Yeah? You agree on that? Now, if we agree on that, Ian, how do you foresee doing studies of that sort, you know, checking an anti-IR5 or anti-TNF in chronic airways disease? What would be the criteria? What sort of patient would you put into the cohort to study? So,
firstly, we are in this really difficult situation where the regulatory authorities, the FDA particularly, require patients who conform to a particular diagnosis. And the difficulty we have is the characteristics that type 2 cytokine blockers inhibit is not confined to those people, and it's not unique to those people, and it's not always seen in those people. So the regulatory authorities, Chowdhury, say you need to go and change your classification. We need a new taxonomy. When you produce that, we will then accept the new taxonomy. But it's up to you. We can't do it. You have to do it. And the guidelines group say, we're not going to change the taxonomy because the regulatory authorities insist that we use. So we're in this uneasy situation. We have to sort it out, I think, because there will be future treatments that, again, don't work well in our current taxonomy. What would I like to happen? Well, I think if you've got a treatment that targets bronchoconstriction, give it to people with bronchoconstriction. So they've got to have the characteristic that the treatment targets. And look at variables that might be associated with response, like smoking, like bronchodilator response, like eosinophilic airway inflammation, but don't assume they are associated with response. Test the hypothesis. So it's possession of the characteristic that you're treating that is the only criteria I would be interested in for future clinical trials. So rather than possession of an arbitrary 100-year-old outdated label, which was relevant in Oslerian times, but is completely irrelevant in the biological era. So that would be, and I'm sorry to go on, but Alvaro Augusti, who sadly is very ill at the moment, and we assembled a group of people last year to talk about this, and we thought, and Guy was one of the, that really it's about identifying treatable traits, so aspects of complex airway disease that we can treat. And that can be operationalized in the clinic by looking for markers of different patterns of disease, rather than labeling the patient and going down a one-size-fits-all type pathway. And that paper is in the ERJ this month, if people are interested. Yeah.
Okay. Thank you, Ian.
Thank you very much.